Hello, my name is Kate Hanneman. In this video, I'll highlight some recent findings from our manuscript titled Increased Spread of Native T1 Assessed by MRI as a Marker of Cardiac Involvement in Fabry Disease, on behalf of my colleagues at the University of Toronto. Fabry disease is an X-linked storage disorder of lysosomal metabolism. Cardiac involvement is the leading cause of mortality, and therefore non-invasive markers of cardiac involvement are needed to identify high-risk patients who might benefit from treatment. Cardiac MRI is routinely used in clinical practice to evaluate for left ventricular hypertrophy and late gadolinium enhancement in patients with Fabry disease, as these findings have been shown to have prognostic significance. Newer cardiac MRI techniques have shown promise in detection of cardiac involvement in Fabry disease. Myocardial native T1 values are low in Fabry disease due to increased glycosphingolipid concentration in the myocardium. Although myocardial glycosphingolipid accumulation lowers native T1 values, other disease processes, including myocyte hypertrophy, fibrosis, and inflammation, increase native T1 values, thus diluting the T1 lowering effect of sphingolipids in Fabry cardiomyopathy in later stages of the disease. The opposing effects of different disease processes on native T1 values may limit the utility of native T1 as a biomarker of cardiac involvement in Fabry disease in isolation. Inflammation and fibrosis are typically regional in Fabry cardiomyopathy with a predilection for the basal to mid-infralateral wall. Therefore, as cardiac involvement progresses, the spread of native T1 values should increase with progressive T1 lowering due to glycosphingolipid accumulation in areas remote from late gadolinium enhancement, for example at the interventricular septum, and progressive T1 increase in myocardial segments with inflammation and/or fibrosis, for example at the basal to mid-infralateral wall. Therefore, we hypothesize that increased spread of segmental myocardial T1 values between segments with glycosphingolipid accumulation and segments with hypertrophy, fibrosis, or inflammation may be a more robust imaging biomarker of cardiac involvement in Fabry disease across the disease severity spectrum. The purpose of our study was to evaluate the diagnostic potential of segmental native T1 spread as an imaging biomarker in Fabry disease. 43 consecutive patients with confirmed Fabry disease and 17 healthy controls were prospectively recruited for cardiac MRI at 3 Tesla, including native T1 mapping. Short-axis native T1 maps at base, mid-ventricle, and apex were contoured in order to calculate global and segmental T1 values according to the American Heart Association 16-segment model. Absolute native T1 spread was calculated as the difference between maximum and minimum segmental native T1 values. We also calculated relative native T1 spread as a percentage of global native T1. This is an example from a 57-year-old male patient with Fabry disease. Short-axis late gadolinium-enhanced cardiac MRI images in the top row demonstrate concentric left ventricular hypertrophy and mid-wall late gadolinium enhancement at the basal to mid-infralateral wall, as shown by the yellow arrows. Corresponding short-axis native T1 maps in the bottom row demonstrate high absolute and relative segmental native T1 spread between segments with high native T1, here at the basal infralateral wall, shown in the blue arrow, and segments with low native T1 at the basal infraseptum, as shown by the green arrow. In our study, we found that absolute and relative segmental native T1 spread were significantly higher in patients with Fabry disease compared to healthy control. Absolute and relative segmental native T1 spread were also correlated positively with quantitative late gadolinium enhancement, left ventricular mass index to body surface area, and global longitudinal strain. Relative segmental native T1 spread differentiated Fabry patients from controls, even after we adjusted for patients' age, sex, and index left ventricular mass. We found that a relative segmental native T1 spread cut point of 9.3% distinguished Fabry patients from controls with sensitivity of 61%, specificity of 100%, and area under the curve of 0.8. We also found that inter-observer agreement was excellent for both absolute and relative segmental native T1 spread. To our knowledge, this prospective study is the first to evaluate segmental native T1 spread as a potential imaging biomarker in Fabry disease. Major findings to arise from our study are that relative segmental native T1 spread is a reproducible, non-invasive imaging biomarker in Fabry disease, discriminates between Fabry patients and controls, and correlates significantly with other imaging parameters, including late gadolinium enhancement, left ventricular mass, and global longitudinal strain. However, there are some important limitations to keep in mind. We calculated segmental native T1 spread using maximum and minimum segmental native T1 values, which might not reflect the actual extreme myocardial native T1 values at the tissue level. Volume averaging could dampen the true maximum spread of native T1 values in an individual patient. Caution should also be used when applying segmental native T1 spread in patients with severe end-stage Fabry cardiomyopathy. In the setting of extensive diffuse ligand enhancement and fibrosis, all segmental native T1 values could be elevated, resulting in low native T1 spread. We believe that the results of this study provide further rationale for native T1 mapping to be applied in all clinical cardiac MRI protocols in patients with known or suspected Fabry disease, given that segmental native T1 spread may provide complementary information and can be evaluated on the same non-contrast images acquired to evaluate absolute native T1 values. Segmental native T1 spread may be particularly useful in Fabry patients who cannot undergo late gadolinium-enhanced imaging due to severe renal dysfunction, allergy to gadolinium-based contrast agents, poor vascular access, or other contraindications. Thank you.